So these are the landmarks for subtotal gastrectomy. These are things we must remember. Any resection on the lesser curvature is only around 2 to 3 centimeters below the EG junction. And on the greater curvature, we have to have these three landmarks. One is where the short gastrics end and the left gastroepiploic start, and at the junction of the left gastroepiploic and right gastroepiploic. So in between these line 1 and 2 is where the partial gastrectomies would be present, or the hemigastrectomies. So as I said, in between these line A and 2, we have to do the partial gastrectomies. Now this is the Merendino procedure, where a resection of proximal stomach with G junction is done, and then we interpose a jejunal segment, which was described in the previous session. This is still possible in a locally advanced gastric cancer, provided we have a stage and the resectability status of this particular patient. So there is no uniform resectional strategies for these patients with locally advanced gastric cancer. It all depends on the response this particular patient gets for the neoadjuvant therapy. Now coming to the resection margins, we all have learned 5 centimeter, 7 centimeter resection margins, but there is little change. A proximal margin of 3 centimeters is recommended for T2 or deeper tumors with an expansive growth pattern. But if it is an infiltrative growth pattern, then you need 5 centimeters margin. For tumors which are invading the esophagus, we always not require more than 5 centimeters. We can always rely on the frozen section and ensure that we get a R0 resection. So the resection margins can be little variable when the esophagus is involved, and not necessarily a 5 or 7 centimeters. If we go by the 5, 7 centimeters, then we always end up doing a esophagogastrectomy for all these patients with locally advanced G junction or the upper gastric tumors. In lymphadenectomy, West still persists on examination of 16 lymph nodes to have a complete surgery. Japan says anything less than D2 is suboptimal for locally advanced gastric cancers. So all of us know the D1, D2, and Professor Palvinu sir will tell us about the D2 and D3 in the later slides. So we should know that for locally advanced gastric cancer, irrespective of the response to the therapy neoadjuvant, anything beyond D2 is what will be required for any site of the gastric cancers. So like in total gastrectomy, this is the lymphadenectomy status which is described. I will not dwell into this one. We will look at the D2 plus dissection. This would be more often required in locally advanced gastric cancers, especially the splenic hilar lymph nodes and also the 14V. And this is one situation where we would need an additional organ resection in terms of splenectomy, even though the spleen is not involved, to get a good lymph node clearance. So not necessarily a T4, but a T3 lesion with good lymph node clearance might require an additional organ resection, and in these local advanced gastric cancers. So level 16 would, after a neoadjuvant chemotherapy, should be also considered in part of the D2 plus lymphadenectomy. We look at a little bit of evidence. The Dutch gastric cancer group trial, they studied D1 versus D2. There was no difference in the overall survival, but definitely the postoperative morbidity was slightly higher. The long-term results of 15-year results show that D2 is better when it comes to the overall survival for these patients. So in the MRC trial, the British trial, no difference in the overall survival, more postoperative morbidity and mortality with D2 and D2 plus. Both the trials have criticized the routine use of pancreaticosplenectomy. Inadequate surgical and post-op quality controls will be there. But having said that, D2 plus is what still they persist, and we should always remember that NCCN guidelines tells us that D1 plus is sufficient if we retrieve 16 plus lymph nodes, because this is more West-oriented guidelines. D2 should be done in only experienced centers, and routine splenectomy is not indicated. These are the NCCN for locally advanced gastric cancer. But the Japanese have a little bit of a different opinion. They say D2 plus is mandatory for all locally advanced gastric cancers, irrespective of their post-neoadjuvant therapy response status. And routine splenectomy is not indicated even in this trial. Only in very bulky splenic hilar lymph nodes, as I said, for want of a complete lymphadenectomy, we should add a splenectomy if we are not able to add much morbidity to them.